Thank you very much for the introduction. I would like to share my screen because I just have a PowerPoint presentation. I have been incorporating virtual care assessment since mid-March. Both of my clinics in Red Deer and in Edmonton, after we got the recommendation from the College of Physicians and Surgeons of Alberta, and we have been advised to incorporate virtual care for most of our patients and only bring urgent cases. This happened in, I believe, the third week of March. So we have tried to be on top of the curve with regards to virtual care. So all of us met in our clinic. We evaluated most of the platforms that we can utilize for virtual care, and we made a decision as a group on which platform to choose and why we choose that platform. I will explain it for you. So I have been mainly doing virtual care for all my patients for the last 2 months. And 90% of my assessments now are done through virtual care, and I only go to the clinic once a week to see essential cases that require therapeutic intervention. So I will try to share with you my experience in virtual care. My presentation is quite basic, and I'm not going to go to too much details. So one of the factors that we realize in physiatry or in medicine in general is that the new norm for how we provide service to our patient is going to be different even after the COVID. And why is that? Because sometimes when you deal with a crisis like the COVID and you're forced to consider alternative methods to deliver your care, you realize the advantage of those methods as long as you realize the disadvantage. And some of us, we realize that some of the telemedicine can be advantageous for our patients moving forward, especially patients coming from a remote location or patient who has limitation with travel and commuting. And it can improve our care delivered to our patients moving forward, even after the resolution of the COVID pandemic. When we started looking at virtual care, we started looking at multiple platforms. There was a platform available through AHS, Alberta Health Services, and it was basically used through through Zoom as well. We had some concerns about Zoom because of the privacy issue and because of the companies that actually own Zoom. We looked at Doxy.me, we looked at Adera Care, we looked at GoToMeeting as well. Most of us, we decided to go with Doxy.me because we did like how it's user-friendly. I will explain quickly my experience with Doxy.me. I don't have any shares in Doxy.me. I don't get any money from their company. But basically with Doxy.me, you have like an easy link. You can give this link to the patient over the phone. You can send it by a text or by an email, and the patient has to click on the link to follow, to get connected with the physician. The patient does not need to download an app like Zoom or like GoToMeeting to go through the link. And the Doxy.me was mainly designed for medical profession. It's very convenient access. Again, the patient can access from a laptop, from a tablet, or from an iPhone. No need for an app. They just need a connection to the Wi-Fi or cellular connection. And it's an easy to follow the instruction. We have integrated in the Doxy.me term of service agreement, and the patient can wait in a waiting room and look at your credential while they are waiting to access you in your waiting room. And you can actually have conference between patient and other allied healthcare, like a physiotherapist or occupational therapist through Doxy.me. You can share your screen with the patient, and you can send documents like prescriptions, requisition for ultrasound, and so on. So basically, the patient, once the patient gets the link, they will have, this will come up and this will show the term and service of the Doxy.me. And once the patient puts their last names, they can read the term and service agreement. This will be my platform. For an example, this screen, and the screen will show if I'm available online or if I'm offline. It will show my credential, and even you can modify your waiting room based on your preference. You can add a picture or you can remove a picture. You can add this term and service agreement and disclosure at the end below the picture, so you play with your waiting room as you want. After the patient reviews this, basically, this is my access. This is my screen access. I have the option of sharing a screen with the patient. I have the option of sending files to the patient. I have the option of conferencing two patients together. And this is basically the option when the patient sees me. And the option of sharing my screen as well with the patient. Sharing a screen is very important when I do an assessment through virtual care, because I can review with them image finding. I have like an anatomy app that uses 3D anatomy to explain for them the pathology and to explain for them if I'm going to do a therapeutic injection or intervention, what exactly is this therapeutic injection or intervention entitled to. So I can explain it that on an anatomy app, and I can do that convenient with my patient. From the advantages that I see in virtual care, first of all, it's convenient access. In one day, I would be seeing patients in Granbury, Fort McMurray, Red Deer, Edmonton, and even from Northwest Territory. In my center at Health Point, we provide a procedure called radio frequency ablation. It's only provided in limited centers, 2-3 centers in Edmonton, and only like 2 centers in Calgary and 1 center in Lacombe. And for those procedures, we get patients even from outside of Alberta. We get patients from Saskatchewan, we get patients from Northwest Territory, because those procedures are not provided even in Saskatchewan, for an example. So it was very convenient that in one day, I limited the travel or commuting for my patient. I was able to contact some of the patients. I will contact them through virtual care on their phone while they are driving. They will park their car on the side of the street. They will finish the assessment, then they will go back to their work. Some in their home. I assist patients as old as 74 years old or older. One of the patients had a hemiplegic stroke with aphasia, and he couldn't express himself. And even his wife was attending with him, and she was able to communicate with me, and I was able to do most of the part of the assessment through virtual assessment. It's very user-friendly. All you have to do is just have like a camera on your phone or a laptop or a tablet with a camera, which is available to most of the patient at this point. It reduces the travel and commuting time. It's cost-effective communication, and reduce actually our need for office space and support staff. I can send the link directly through my DocsMe to the patients. And even if I'm on phone with the patient and I want to switch them, all I have to do is just send them a text with my link, and the patient can have access. From my assessment, most of musculoskeletal pathology or spine pathology, it's more falling within patterns, and those patterns, and based on prevalence, based on patient demographics, based on patient presentation, we can narrow those patterns to 1 or 2 patterns. Yes, physical exam is very important, but most of the time before I actually examine my patient, I already have 2 diagnoses that are on top of my list, and maybe 1 diagnosis that I want to rule out. And the physical exam will help me to do that. During the COVID pandemic, what we have been trying to do is we have been trying to limit any patients that come for physical exam till it's necessary. So for example, if I'm looking at electrodiagnostic screen for a patient with carpal tunnel syndrome, all I have to do is to look at the hand of the patient to make sure that he doesn't have atrophy. I can look for functional use of the hand to make sure that all the intrinsic muscles are still intact. If I don't see any evidence of atrophy or significant weakness, most likely the symptoms is mild, and most likely the symptoms can wait. So I can give the patient an instruction on how to address those symptoms, and I can give the patient my diagnosis and my secondary diagnosis, and tell the patient to wait for 8 weeks to try those conservative treatment, and then reassess after. If the conservative treatment is successful, most likely that confirms the diagnosis, and at that time we don't actually need to bring the patient urgently or necessarily for a clinic visit or even for a nervous study. If the conservative treatment fails, for an example, then I will need to bring the patient for a full assessment and rule out any other underlying diagnosis. So with virtual assessment, we can do most of our range of motion, we can do most of our inspection. The limitation will be with our palpation, figuring out where is the most painful area is, and also limitation with performing special tests. With palpation, most of the time I ask my patient to point for me where does it hurt the most. So I will get them to use one finger and try to point where does it hurt the most, and I can guide them on my body where it hurts the most. Then I can use the Essential Anatomy 3 app to show them which joint is the most painful or where I'm suspecting their pain coming from. I still have a limitation because I can't do a full neurological exam, because I cannot do a sensory exam. I cannot do reflexes through virtual care. I cannot do my special tests. For example, if I'm assessing patient with rotator cuff tendon damage, Sometimes I can get away with asking the patient to do the special test on the screen with me, but that's not as accurate as if I perform the special test. Especially when I look for joint stability or laxity, I can't do that through virtual assessment. But those information I can collect it from imaging evaluation and also from seeing how the patient move in front of me through virtual care. Disadvantage of virtual care. As I mentioned, we have limitations in our assessment. It's not a full assessment yet. From medical legal perspective, for example, one of the most common complaints that we get from car accident is a chronic mechanical neck pain or a whiplash associated disorder. If there is no neurological limitations, and if there is no neurological symptoms associated with the patient presentation, I feel that the physical exam has very limited value. Because most of the assessment can be done by looking at the patient range of motion, looking at the patient where he localized the pain, and at the end is the most accurate way to confirm the pain generator in cervical spine and lumbar spine is actually for a diagnostic block. This diagnostic block is done for specific facet joints, and basically we can do that under X-ray. So if the assessment is limited through the virtual assessment, I will bring the patient in and I will examine them again under X-ray or under fluoroscopy. And then I will localize the most painful joint, and then I will proceed with the diagnostic block, which is going to confirm my diagnosis. So most of the time, if my assessment is limited, I will combine my assessment with the intervention that I will do when the patient comes for a clinic visit. It's a learning curve for all of us, and it changes hard on everybody. And sometimes some of us are early adopters, some of us are late adopters, but I try to be an early adopter and try to incorporate this change because I believe telemedicine will be the future of how we develop or how we deliver medical care. And we can actually use this to our advantage to improve care provided to our patient. As we recognized before, technology and Wi-Fi limitations, sometimes if I'm contacting with a patient and the patient has poor Wi-Fi access, it's gonna interfere with the video quality and with the audio quality. I have switched some of my assessment to just phone calls because I couldn't get good quality for video and audio conferencing. And that's limitation from usually the patient side, not from my side. There is some concerns about interception and disclosure by third party, because again, none of those platforms are regulated by Alberta Health Services. And that's concern us that they can have access to the collected information and they can distribute this access, or someone can hack the system, take pictures for the patient, or have access to the information distributed by the physician to his patient. We need for sure more regulated technologies, and again, we need this to be available. And the other disadvantage, none of those platform was already designed during the COVID. So the extra workload or the extra use for those platforms can reduce the quality of using those platforms. So that's it for my presentation. I hope I was on time, and I'm happy to answer any questions.